Welcome to Grand Rounds. We are in April 2021. So today we have Dr. Frank Buzin coming to talk to us. He graduated from Westchester University with a bachelor's degree in biology, and he received his Doctor of Physical Therapy degree from Slippery Rock University. After completing his postdoctoral fellowship in orthopedic manual physical therapy, Dr. Buzin earned the distinction of Fellow of the American Academy of Orthopedic Manual Physical Therapy. This is a distinction that less than 1% of all physical therapists in the U.S. have received. Dr. Buzin had worked in private practice for 5 years prior to joining St. Luke's University Health Network, and is currently the facility director at the Bath office. He is an advanced spine care practitioner through the St. Luke's, and he's clinical faculty for both the St. Luke's University Health Network Orthopedic Residency and Spine Fellowship. Dr. Buzin is also an instructor at Mid-Atlantic Manual Therapy Consultants, which is a continuing education provider focusing on teaching hands-on techniques for orthopedic conditions. And he's taught many providers how to improve outcomes for patients with thoracic outlet syndrome.
Friday. And
so I'm going to ask that everybody make sure that they mute themselves because this is being recorded, and also just so that there's not background noise. Without further ado, I will turn this over to Dr. Buzin. So he's talking about thoracic outlet syndrome. It has seen you.
Thank you, Steve. Okay. Good afternoon, everyone. Hope everyone's having a nice day on this as it starts to rain outside. Just pulling up the presentation. So today, it'll be my pleasure to talk about thoracic outlet syndrome, a condition that is controversial in the terms of physical therapy as well as when we speak to physicians. So before I go into it, I'll let everyone know that our activity description is to bring better understanding of thoracic outlet syndrome, diagnosis and treatment to all providers. And then we have our designation statement, which is required. We have no financial relationships to disclose. Learning objectives. Today, hopefully the participant will be able to discuss the anatomy and biomechanics of the rib cage, T-spine, thoracic outlet, and explain their role in the true diagnosis and treatment of the syndrome. Be able to discuss the influence of the thoracic spine and rib cage on shoulder function, as this has a big input on the thoracic outlet, as well as on patient symptoms. Participant will understand and be able to select manual therapy interventions, design an exercise program, guided by available evidence and clinical examination, which we'll go over, and also describe and perform most relevant testing for the thoracic outlet. So introduction, we'll discuss the anatomy of the upper rib cage and thoracic outlet. The content incorporates examination and overview of treatment approaches for the TOS. So oftentimes it's a repetitive strain injury that occurs. So definition, originally coined in 1956 to indicate the compression of neurovascular structures in the interscalene triangle, corresponding to possible cause of symptoms. Symptom complex caused by compression of the nerves and or vessels in the neck and shoulder, and emerged as a very controversial topic in medicine and rehabilitation. It's not a true definition, but only it outlines the location of the problem. So understanding where these things can be, where the nerves or neurovascular bundle itself can be hung up, is a big thing to consider. So the definition, that was pretty much a poor definition to consider of that being so widely grouped together. So oftentimes you'll see venous, arterial, or neurogenic, and neurogenic can be further broken down into true and disputed, which occurs 90% of the time. So true, we'll discuss more about true neurogenic and also and disputed, which will be what we see in the clinic. So many providers have coined or used different terms with regards to this syndrome. If cervical rib syndrome, if anyone's seen that on plain film, pec minor syndrome, scalene anticus, which is just an extrascalene muscle which can occur, Costoclavicular syndrome, which is the space right below the clavicle in the first rib, brachial plexus syndrome, shoulder arm syndrome, dead arm syndrome, cervical axillary syndrome, cervical outlet syndrome. So you can start to think about a lot of baseball players will end up with this condition. One of the most famous ones, most recently being Matt Harvey, a couple years ago, ended up having the first rib resection just to clear space for this, just because of the history of repetitive overhead activity. Prevalence of TOS, majority of individuals are between the ages of 20 to 50, female being more likely than male, approximately 3 to 4 times more common. This is due to anatomical and strength variations. Vascular TOS, approximately equal in male and the non-athletes compared to female, in comparison to females, and it's higher in athletic males as well, just a history of overhead activity. So this was pretty interesting. In 1999, 2 researchers came out, one saying that TOS is underrated, the other one saying it's overdiagnosed. Bruce test, which is something that we'll go into, also another term is elevated stress test. With that, it's something that we all learned in school and played around with, just clamping your fingers together and seeing if it reproduces symptoms. So these are tests that many of us do not perform in the clinic. We just sort of jump right into our examination, but we'll definitely go into that. Predisposing factors, things to consider anatomy-wise: elongated C7 transverse process, a cervical rib. So cervical rib will be picked up on plain film. However, in our clinic setting, if we do not have any type of plain films before the patient gets to us, you can start to think of if someone appears that their first rib is elevated by about ½ an inch in comparison from one side versus the other side, we can start to think that that could be a cervical rib being present. I remember hearing a story of a colleague of mine who was teaching at a school. The teacher performed a first rib grade 5 mobilization on a student, not realizing that it was a cervical rib, ended up sending her into a full-blown radiculopathy. So these are things that we have to consider before we do our types of treatments and interventions. There can also be anomalies present, fibrous bands that can be interlacing through the brachial plexus, as well as a neurovascular bundle, and accessory scalene muscles, as we talked about previously with the scalene anticus. This is a picture of a thoracic outlet syndrome. So you can start to see there are certain areas where the subclavian artery and the brachial plexus can be impinged upon. So in this picture, we have our clavicle, which is A, and that just sits right above our first rib. We have our pec minor, which is labeled as H, and also too our scalenes, which are located higher up next to I, which is this sternocleidomastoid. We'll be able to see this in a better picture coming up. So the thoracic outlet itself is comprised of 3 gates or compression sites. We think about our scalene triangle between the anterior and middle scalenes. This is where the trunk of our brachial plexus exits. Our costoclavicular space between the first rib and the clavicle. So if everyone can palpate on themselves, right directly below their clavicle and moving in towards their sternum, that little area right there is, believe it or not, your first rib. If you move a little bit more out towards the side, that's your second rib. So, and then you have your clavicle. So that's a very tight space where things could hang up at. Then we have our coraco-thoraco-pectoral gate, which is just where the coracoid process, the thoracic spine, and the pec minor meet. We'll see that in the next picture. So that last structure can be seen by the pec minor, which attaches to our coracoid process and our 3rd, 4th, and 5th ribs. So we start to figure if we have a tight pec minor, it can throw off our thoracic spine, just sort of give that forward rounded shoulder position. Then we also have our brachial plexus, which can get impinged upon more so between the anterior and middle scalenes, as we talked about, and also below our first rib and our subclavian artery. Excuse me, our first rib and our clavicle. So you can start to see different anatomical variances can start to have a play in how a patient presents to us. So remember this picture and we'll go further in depth into it, as well as scapular positioning and clavicle positioning. So quickly talk about arterial thoracic outlet syndrome. History, often in young adults. Possible vigorous overhead arm activity. Spontaneous onset. Signs and symptoms, claudication or rest pain of the upper extremity, excluding the shoulder and neck. So this is something to think about if someone comes in with neck pain and symptoms going down the arm, younger athlete. Will this be something that we can either include or exclude? So there will actually be numbness, coolness, and pale skin. You'll actually see physically one side compared to the other side. They'll most often have a coldness or cold intolerance, and of course, complaining of numbness and tingling. Examination, positive elevated arm stress test or a RUSE test, upper limb tension tests, which we will discuss a little bit further, and Adson's tests. This is confirmed through Doppler ultrasound or CT with MRA with positional testing. The position of testing will be the arm fully into abduction position. Then we have venous thoracic outlet syndrome. Once again, often younger individuals, most likely being male. History of overhead excessive arm activity with spontaneous onset. Deep pain, which is not considered more muscular in nature, but just deep inside, almost that it's really eating away at the patient, with movement or rest pain in the upper extremity, chest, and shoulder. So we can start to think of almost like a blood clot presentation. The patient will present with color changes in their hand, oftentimes appearing blue with visible swelling. So there's a difference to consider of someone saying, my hand feels swollen, and not seeing those changes versus actually seeing those physical changes. And they may complain of feeling of heaviness with use of their upper extremity. And the same positive tests, elevated arm stress test, upper limb tension test, and Adson's test. This is confirmed through Doppler ultrasound or CT MR venography with positional changes or a contrast venography. And then this is the one that most of us will see in the clinic, neurogenic thoracic outlet syndrome. History of neck trauma, oftentimes post-MVA or repetitive stress at work, muscle imbalances, and poor scapular positioning, things that we see nearly every day. Findings, so it's all over the place. You got pain in the neck, trap, shoulder, arm, chest, and occipital headache, so a headache right at the base of your skull. Paresthesias, numbness during day and night, sleep disturbances. Oftentimes patients will say they wake up with their arm feeling numb or tingling. Arm weakness, they feel that their arm is not as strong as their opposite arm. Difficulty with repetitive, sustained overhead activity. This is one to consider right here of what can set off a differential diagnosis, because there will be a lot of different ones to consider, of repetitive, sustained overhead activity, just because of the compression of one of the triangles. Examination, tenderness of palpation on the scalene triangle and or the subcoracoid pec minor space. So once you get in there, you can really feel for it. Okay. Also, sensory changes in the arm and hand. You can do pinprick sensation, light touch sensation, however you want to test it. There'll actually be sensory changes. Weakness and atrophy, possibly in the deltoid biceps, hand, wrist, fingers, and can be present with concurrent distal compression syndrome. So we think about carpal tunnel syndrome, cubital tunnel syndrome presentations, always looking further up the chain. So true neurogenic thoracic outlet syndrome, objectified weakness. So this one we can actually see a change, for example, in a dynamometer grip strength testing. You'll see the one difference, one side will be a lot weaker compared to the other side. Also, too, you'll see a positive nerve conduction velocity or EMG test. This is important to consider what just due to the integrity of the nervous system. You need about 80% compression of a nerve for an EMG to come back positive. So this is more of a serious condition. You'll also see at least 2 positive provocational tests, which we'll get into. I think we will discuss 6 or 7. Then we get into disputed. So this is one where the EMG comes back negative, nerve conduction velocity test is within normal limits, and you will often see a positive Cyriax release test or phenomenon, which we'll definitely go into further on. It can coexist with venous TOS. So if someone presents with arterial or venous TOS, that's more of a surgical emergency at that time. So further going into neurogenic disputed, main cause is traction injury, either traction or due to poor posture. The posture of how a patient's sitting, posture of how a patient's shoulder blade is positioned, or just due to traction of the nerve when they're reaching up. So when you actually reach up towards the ceiling, your arm is putting that nerve on traction. You'll see negative imaging and vascular studies. So by the time they get to us, they might have had an MRI, CT scan, Doppler study to help rule everything out. Other terms for this are postural TOS, symptomatic TOS, or nonspecific thoracic outlet syndrome. So there's two different parts of the plexus that can get hung up. Clinical presentation of the lower plexus would be pain at the base of the neck, radiating symptoms down the ulnar aspect of the forearm into the hand, severe headaches at the base of the skull, radiating over the top of the head associated with arm use. So that's something to consider, is asking the patient, hey, when you use your arm, does that sort of radiate over your head, cause headaches, those types of things? It's hard for most individuals to correlate the two. In some patients, the pain may radiate through the front of the chest, simulating cardiac angina. In more advanced cases, weakness of the hand and loss of dexterity of the fingers frequently develop. Arm extension and elevation typically aggravates the symptoms. So this is something to consider. The symptoms should be intermittent. There should be positions that make them feel better versus positions that will make them feel worse. And also too, if we remember our neuro testing, possibly will be present weakness of elbow extension versus elbow flexion just due to the lower root involvement. Upper plexus involvement, pain in the neck, same as with the lower brachial plexus. Pain radiating upward towards the ear, face, and temple, and one side of their head, headaches. Pain radiating to the upper pectoral region, to trap and down the lower arm. May oftentimes complain of stuffiness in their ear. Tinel sign of tapping into the trap and rhomboid, and also may see thinner weakness and a Tinel sign in the neck. Imaging to diagnose TOS may help to rule out cervical spondylosis, shoulder joint pathology, or long apex pathology. So we want to help rule out as well, not listed on this, is cervical radiculopathy through an MRI, through a disc, or other type of nerve impingement higher up. Imaging allows for accurate classification in neurogenic, venous, and arterial TOS. Abduction of the upper limb is a positional choice for cross-section imaging. Usually plain films and cervical MRI are performed. This is pretty interesting. I attended a presentation by Dr. Succumbi with regards to a top neurosurgeon in Philadelphia. We gave a presentation on thoracic outlet syndrome who talked about cervical MRI and plain films were sort of his gold standard on being able to diagnose this. So it's just something to consider. When a patient says that they had an x-ray performed, came back negative, or came back positive for a cervical rib to consider. I had a young lady, she had bilateral cervical ribs, but she only had symptoms going down one arm. Her entire position of provocation was overhead activities. So once we got that under control, it improved her symptoms. So it's one of those, what caused the symptoms to come on? Because she's had that cervical rib for her entire life. So differential diagnosis, long list of ones to include. So carpal tunnel syndrome, cubital tunnel syndrome, ulnar neuropathy, radiculopathy, clavicle fracture, AC joint irritation or injury, elbow forearm overuse, cervical thoracic disc, shoulder impingement, cuff pathology, Pancoast tumor, CRPS, MS, Raynaud's phenomenon, T4 syndrome. So there's a lot of different things that we would have to consider and rule out with our diagnosis of correctly identifying if it's the syndrome. So on our next slide, currently right here, is a Pancoast tumor. It happens in 3 to 5% of all lung cancers. Men greater than women, age greater than 60, history of smoking. Initial symptoms are usually pain in the shoulder, scapular region, axilla, possibly referring pain to C8, T2 dermatomes, start to see atrophy in the hand, arm, and forearm with the frequent need to support the elbow. So that's where another one it comes into play of taking good history is identifying patients' comorbidities and overall general health. So now we get into examination. This is where I truly identify what's going on. It's nice to know the definition and where things can get hung up, but it's our job to be able to identify where exactly our treatment is needed. So it all begins with a thorough history and subjective exam. We ask the patient, was it something that came on gradual? Was it something that came on all of a sudden, just overnight? Is it bilateral or unilateral symptoms? Usually it's unilateral. If we start to think bilateral, then it's coming from the neck, often majority of the time. Did they have a history of a history of an MVA recently? Any MVAs in the past? Currently, I'm treating a gal right now who had an MVA 2 years ago, who now has limitations with performing overhead activity for a period of time. So it could have been one of those that just starting a new job, changing sleep patterns, carrying her daughter has all brought these to the forefront. Any other cervical traumas, any type of whiplash injury, impact to the head, things that they might not be considering, things that have happened in the past, change in activity status. They went from a desk job to doing a lot of tasks overhead, or just started doing more and more upper extremity related tasks. They started now we're now in the warehouse valley. So they started doing one of those, picking more things at Amazon. Well, also too, asking other unrelated upper extremity problems. You never know. Someone goes, oh, I've never had surgery in the past. You start to get into your exam and they go, oh, I did have rotator cuff surgery, or I did have a rotator cuff pathology, which they didn't think to include. We also want to ask them time of day symptom occurrence. Are there releases? Things that will cause this to flush and come on. We start to think about if a garden hose, if that hose is being squeezed for so long, that water starts to trickle out. Now we finally get to nighttime. We take that pressure off just of how we're sleeping. Now we get that flushing sensation. That flushing sensation can be considered numbness, tingling, paresthesias, however, burning, different things to consider with that. We start to think about compressors. Are they activity dependent? With reaching overhead, reaching forward for periods of time, sitting for periods of time, just the changes in their scapular positioning. So we want to identify provoking and alleviating factors with this. Does it feel better if you have your arm over your head? Does it feel better if you sit supported? How do you feel when you're sleeping for a period of time? They'll say, oftentimes, I'm able to sleep for a few hours, and then exactly at that same time every night, I just wake up. So symptom location, many different areas that a patient can experience symptoms. So often 98% of the time, which is almost significant, which is significant, is paresthesia in the upper limb, neck pain, trap pain, shoulder and arm pain, supraclavicular pain, chest pain, headaches, fourth and fifth finger, first, third fingers, paresthesia in all 5 fingers. So pretty much this is anyone that comes in with numbness and tingling in their arm, just to be considered. Our objective examination. We want to take into consideration the standing posture, the spinal positioning and the scapular positioning, supraclavicular fullness, so the area right above the clavicle when observing from the front, and also to upper extremity observation, checking if there's any swelling, color change, or hand atrophy. So this picture right here, this young man, we can say, if you look at the left scapula versus the right scapula is sitting lower. Also too, it is winged just because of the aspect of the inferior angle, which is the lowest part of the scapula, is more prominent. And we can also see that the inferior angle, or see, there's no way that I can point out this, is there? Yeah. Okay. Little pen.
So if you go over, yeah, there you go.
Oh, perfect, thank you. So this is the inferior angle of the scapula, superior angle. So this is more prominent, therefore it's winging, anterior tilted, and also too, we'll get further into it, other scapular syndromes. Excuse me. Oh. Then we get into shoulder girdle posture. So we can look right here. So this is the right arm. We look at the AC joint, which is right here. SC joint, which is right in this position. We want to look at the angle of inclination, which should be 10 to 20 degrees, which it is. We start to have a little bit more fullness on this aspect compared to the uninvolved side. And also too, if there's any type of pec change, which there seems to be more tone on this side compared to this side in the picture. And also we want to look at from the side. We want to look at the head positioning, see if the ear is in line with the acromion, see what's going on with the clavicles. We can see that this one looks like it's in rather good position. We'll also check what's happening with the scapular region, and we can notice that the scapula is very prominent from this position. So objective examination. We want to look at cervical active range of motion with overpressure in all directions, except for extension, of course. Passive range of motion, all planes, supine. We want to see if the patient fits into a cervical radiculopathy category. So with that, it would be positive Sperling's test, positive distraction, active range of motion less than 60 degrees, and upper limb tension test being positive, usually of the median nerve. So if any of these are considered positive, there's no further needing to test for thoracic outlet syndrome, just because we can understand that everything's coming from the neck. So clinical testing for TOS. We have our sensitivity and specificities listed right here. So the tests that we will go into are the elevated arm stress test, Wright's test, C-rex release, supraclavicular pressure, costoclavicular maneuver, upper limb tension test, and cervical rotation lateral flexion test. So with regards to these, it's better to have them performed in clusters. And right here, just because there's no true gold standard for TOS. High rate of false positives. Recommendations are history taking, understanding how the patient is presenting to us. So 2 to 3 provocative tests, if they're negative. We can be pretty much 90% confident that a patient does not present with thoracic outlet syndrome. 5 provocative tests, 84% confident that the patient is presenting with this. Adson's test is no longer recommended. That is the one where you check the pulse and you take the person's arm into a certain position and move their head. It's just too unreliable, according to a study performed in 2014. So our testing of our first rib, which a lot of clinicians believe is always elevated. So a test that has 100% sensitivity is the cervical rotation lateral flexion test. This is what it looks like. We will have the patient fully rotate their head. They must have full rotation available. And then the side that is being tested is the one that has the ear up. So in this picture right here, the patient is having their right first rib tested. So we are testing to see how much lateral flexion they can truly achieve, comparing one to the opposite side. It must be fairly noticeable. We're not looking for symptom reproduction. If symptoms are reproduced, that's an added bonus. We are looking for true excursion and range of motion. Then our C-rex release test. Patient is seated with elbows flexed to 90 degrees. Picture will be shown next. And pillows under the forearms, head and neck are neutral. The therapist stands behind the patient and passively raises the shoulder girdles. The position is held until peripheral symptoms are reproduced. So with this is that release factor. Think about that hose example. We are trying to take pressure off the neurovascular bundle. So with regards to this, if symptoms are reproduced if symptoms are reproduced and it take a less than 1 minute to occur, specificity is 97%, which is really good. We want to document the type of symptoms and location as well, and how long the symptoms took until they were provoked. The paresthesia and numbness appear first, and then they normalize. Often with nocturnal symptoms, 5, 6, 7 hours into sleep, and this will be fairly consistent every time. And here it is pictured. So the clinician is elevating both scapula, trying to take pressure off one of the gates of the thoracic outlet. We have our elevated arm stress test, which is our Roos test right here. Trying to get away from naming after certain individuals. So our elevated arm stress test. Patient seated with arms greater than 90 degrees of shoulder abduction and elbow flexion with full external rotation and head neutral. Patient opens and closes hands into fists repetitively for up to 3 minutes. Positive test, pain paresthesia reproduced and relieved with arms lowering. Higher sensitivity when it takes longer than 90 seconds to bring on symptoms. Specificity, not very good, 30 to 100%. So that's all over the map. The therapist may use fingers to apply downward pressure to help with this. We want to document the location. Going back to one of the differential diagnoses of cubital tunnel syndrome. So if it starts to reproduce any symptoms in the elbow to help separate the two, it would just be to have the patient extend their arm slightly to take pressure off the compression site at the olecranon region. We have our supraclavicular pressure test. Patient seated with arms at the side. Patient squeezes the finger on the upper trap and thumb on the anterior scalene, which will be pictured next. Compression will be held for 30 seconds. Positive test, pain paresthesia reproduced and relieved with compression released. We want to compare one side to the other side. So here it is right here. You see the thumb is on the anterior aspect of the anterior scalene, and we're sort of just squeezing the upper trap. Costoclavicular maneuver. This is our military test position. So you start to think of someone having their shoulder girdles retracted while protruding their chest up. The clinician can help if needed. Positive test is pain paresthesia reproduced or changed in pulse, which is not recommended by recent studies. This test compares one side to the other side. Here it is pictured. Then we have our right test, which evaluates the brachial plexus beneath the pec minor. So all these tests will show different compression sites and where to identify potentially where you need to perform your treatment. Patient seated with the arm at the side. Here you can assess radial pulse, then abduct arm overhead, holding for 1 to 2 minutes. We're looking for a change in pulse, which, as many of us who performed this in school can remember, that most of us test positive for this. It's just one of those types of things. So we're looking for the reproduction of their symptoms and pain and paresthesia. Here it is positioned. So this slide helps you to identify exactly where to look. So the right test, test under the pec minor. Supraclavicular pressure test, we look for between our anterior middle scalene. Our upper limb tension test, which we'll go into next, just allows us to identify general thoracic outlet syndrome. Our cervical rotation lateral flexion test and costoclavicular maneuver are compression at the costoclavicular space. Once again, that little area that's in between the first rib and the clavicle. So median neurodynamic test or the upper limb tension test, median nerve is pictured right here. We have our radial nerve and our ulnar nerve. So if any of these are positive, they are considered a potential indicator of thoracic outlet syndrome. With regards to comparison to the opposite side, as well as in combination to our other tests that we previously discussed. So we get into further examination. So we discussed about our positional testing. Now we also want to assess our mobility testing. So we want to assess first rib mobility testing. So we did that through our cervical rotation lateral flexion test, and also with our spring testing, or our spring testing of the first rib, either performed in sitting or supine. Second rib mobility testing, we want to do palpation to see if there's any type of joint positional fault where the rib can be elevated or it can be forward or back. It can also be done in prone or supine. Other rib mobility testing, this is an area to consider when it comes to the shoulder girdle. Just because if someone has insufficiency of a scapular upward rotation or being able to lift their arm fully overhead, they can actually have a rib dysfunction. This is one where individuals start to think that they have a knot in their back, or they could have some chest pain when it's more of a rib dysfunction. So you treat that, it'll help improve their middle trap strength, lower trap strength, serratus anterior strength, can reduce tone in their pec minor just because of the attachments of the third, fourth, and fifth rib. So we treat that, can actually improve their scapular positioning. As we talked about, your scapula, and we'll get further into it, your scapular positioning can have a great impact on the thoracic outlet itself. We'd also want to check the AC joint mobility testing and SC, which stands for sternoclavicular joint mobility testing. So with regards to this, our scapular testing, we want to see if a patient presents with scapular shoulder girdle depression. This is where the superior angle sits below T2, spinous process, and the inferior angle as well sits below T7. Long neck appearance, which happens in a lot of women, just how their anatomy is. The AC joint and the SC joint are at the same height. So this is where the clavicle minimally elevated or flat. Going back to the picture of that gentleman, we saw that he had pretty good inclination. Most individuals who present with this will have a flat positioned scapula or flat positioned clavicle. We'll see an elongated upper trap, shortened pec minor, and a nice comparable test is to just passively elevate their shoulder girdle, and if it reduces their symptoms and improves their range of motion or causes that release effect, that's considered a positive finding. We have our downwardly rotated scapula. The inferior angle sits closer towards the spine compared to the superior angle, which we discussed. We want to assess statically and dynamic. During dynamic, we are looking for that inferior angle to reach the mid aspect of the armpit. May see elongated upper trap, serratus anterior, shortened rhomboids. So this could be someone who has been doing a lot of chest exercises, more of the military type positioning. Once again, the PT provides passive elevation and puts them in better positioning, and we assess for a symptom change. We get into an anterior tilted or winged scapula, as the gentleman in the previous picture had, in the previous pictures had. We look for a prominent inferior angle, which is called tilting, prominent medial scapular border, which is winging. You can assess for a tight pec short minor, long lower trap, so to test for that. Patient laying on their stomach, arm out to the side, into 110, 120 degrees of shoulder abduction and push down. See, oftentimes you'll see one side will be a lot weaker than the other. Poor control of the serratus anterior, which is one of those, when in doubt, you can always strengthen the serratus anterior. With this, same thing as previously, putting them in the optimum position. The optimum position, the superior angle is even to T2 and T7 and sits parallel to the spine of the person. We want to compare one side to the other side. Then we get into deep neck flexor testing. Oftentimes, the anterior longus and coli are weak or insufficient, and by strengthening these will improve your head position, as most individuals who present with this condition will have forward head posture. To perform this, patient is supine, pillow used as needed. The patient's cued to nod their chin down. Clinician can help lift their head 1 to 2 inches up off the pillow and ask to hold. With this, we are looking for compensations. Compensations can include SCM activation, which is the muscle right here. We are looking for a loss in the roll that is created when nodding the chin down. A gold standard of this is 40 seconds. So if a patient cannot hold for that, that gives us something that we need to work on. So now we get into treatment objectives. We understand how to assess for it. Now we need to know what to do for treatment. Treatment objectives. We want to improve the scapular position or posture and dynamic control of the person, optimize space of all 3 gates, maintain postural awareness and control, and progress to independence with self-treatment and management. If someone keeps working overhead for hours at a time, there's nothing that we can do to really influence and change their symptoms except for educate them and teach them rest periods or different positions to go into to help alleviate some of their symptoms, but there'll be nothing that can take fully away their symptoms. Treatment considerations: 60 to 70% of all patients with neurogenic TOS are successful with avoidance of activities that precipitate symptoms, ergonomic modifications, medications. Physical therapy is often recommended for 8 to 12 weeks prior to surgical consideration. If they fail after these 2 to 3 months, a lidocaine scalene block is given. If that improves their symptoms, then they're a likely candidate. Surgery is indicated when there's true neurological signs present: weakness, wasting of the hand intrinsic muscles, and also too when the nerve conduction velocity is less than 60 meters per second. Usually the surgery of choice is a first rib resection and anterior splenectomy. Most common complication, approximately 10% of the time, is just normal thorax, a little bit of fluid into the thoracic region. Symptom reoccurrence or surgical failure, approximately 10% of the time. Manual therapy interventions, things that we can do to make changes in what a patient presents with. First and second rib mobilizations, grade 5 mobilizations, graded mobilizations, however you choose to perform it. Other rib mobilizations, SC joint mobilizations, AC joint mobilizations, cervical and thoracic, and glenohumeral joint. If the head of the humerus is sitting too far forward, these are different things to consider. Soft tissue mobilizations can be performed to the scalene. So putting the patient in a position of non-provocation and just working and loosening up the tight musculature. Then we have our pec minor. This is just doing a myofascial release, sustained hold. You can also add it with movement, strain, counter strain, however you prefer to perform your soft tissue mobilizations. And Grassin, I had really excellent results with negative pressure soft tissue mobilization or cupping, just to take pressure off the region, and then have them move into those areas of positional provocation. And we also have our subclavius, which most of us forgot about, which is the muscle that connects the first rib to the clavicle. So if this area is tight, it'll compress that one triangle that we're trying to improve upon. Then in conjunction with soft tissue mobilizations, joint mobilizations, our taping is taping. So with taping, we can improve the upper trap. Majority of the individuals and clinicians do upper trap stretching. You'll find that the upper trap is blamed in a lot of situations when truly it is excessively long or lengthened, when if you shorten that muscle, it improves their symptoms. So if we go back to think about the position of the AC joint and the SC joint, if that loses that angle of inclination and we improve that, that's also improving the upper trap, just given the origin and insertion, and that'll help improve cervical motion and arm motion. So in this picture, the clinician is providing taping intervention with coverall to protect the skin. Then we have the elbow supported to shorten the upper trap. And then we are taping in a direction of distal to proximal. Oh, I'm sorry. There we go. Then we also get into postural taping. We can do an X taping, can just be for general cueing, can also be for symptom reduction. We'll find that just by putting the tape on, a person will become more cognizant of their positioning. Try not to become reliant on this, but this is used in combination with exercise. Exercise, what does that look like? Self-neuromobilizations. However you want to treat the nervous system, you can, whatever nerve that you found to be irritated, median nerve, ulnar nerve, radial nerve. You can treat through self-rib spinal mobilizations, teaching the different techniques. Breathing retraining, something that we didn't get into, is just upper chest dominant breathing, which you will have your accessory muscles kicking in, which would be the anterior scalene, the upper trap, and the levator. So watching how someone breathes can make a world of change by cueing them for diaphragmatic breathing and changing their rib excursion. And that's also tied into the thoracic region. Correction of muscle imbalance, some muscles that we discussed previously. Deep neck flexors, right here, can be trained during, it's more of an endurance-based exercise using a blood pressure cuff to help retrain that and giving the biofeedback to a patient is very important, as most people will activate the wrong musculature. Upper trap, this is an exercise, a touchdown, where you're actually putting the muscle in a shortened position. That can go back to Shirley Sarman, if anyone's heard of her. She believes the best way to strengthen a muscle in its shortened state. So this can be done during the day, numerous times. 5 repetitions holding for 10 seconds. More and more that the patient does it, the better it is, just because as you go throughout your day, rarely do we find our arms overhead. And we have our serratus anterior, which is a wall slide. So the serratus anterior, its function is to protract the scapula or push it forward at 120 degrees of elevation. So that's the position that this gentleman is in, and he's just sliding up the wall, just trying to improve his shoulder blade position. General exercise principles: avoid heavy resistance and load with exercise. The idea is trying to make postural changes, not necessarily trying to bulk up a muscle. We want to avoid the recurrence of symptoms during or shortly after exercise or activity, as this is when most of the symptoms will occur. Avoid compensation from the accessory muscles, the scalenes, the upper trap, the levator, as we discussed. Progress gradually, educate the patient on not overdoing it, and keep reps low and emphasize frequency. As we know, during the day, you can do 3 sets of 10 of scapular retractions, spend the rest of the day in a forward shoulder position. You're not going to make any changes whatsoever. Then we get into our postural education, sitting posture, passive shoulder girdle elevation, using armrests, pillows. We're getting more into the summer season, so if anyone has their beach towel laying around, we'd also want proper chair height, armrest setup. We feel most individuals that I see in the offices are more shorter, petite women, where the chair is not made for them whatsoever. And we also want to take into consideration standing posture with reaching, lifting, bra straps, changing how, and just having that conversation with each female to let them know that the bra strap can be pulling them down. I had a gal, she would go horseback riding, and that would be the only time when her symptoms would be brought on, was just due to the bra that she was wearing. So changing that up actually improved her symptoms without having to do any type of manual intervention, which is nice. And also 2 sleep postures, different things to consider. I will open it up for any questions to anyone. Anything I need to do, take them all.
I have a question.
Sure.
You demonstrated the cervical rotation lateral flexion test in supine.
Yes.
What are the implications of doing the same test in sitting?
There aren't any. However, a person will be more likely to achieve further cervical rotation passively in a supine position than they are in a seated position. It comes down to person preference and also to the ability for a patient to move.
One question that was online is for the Cyriax test.
Yes.
This increases or relieves symptoms. So a positive test would be increasing of symptoms or relieving of symptoms.
So we are looking to bring on their symptoms just because of overhead activity, and the way that certain things are produced during the day can cause a compression. So the release phenomenon is the relaxation of the vessels. So if they've been compressed for so long, now we're taking pressure off that region, which will cause that flushing effect. And the flushing effect is the burning or that numbness and tingling. And if we keep them there long enough, 5 minutes, 10 minutes or so, it'll alleviate their symptoms completely. So that's an exercise that we'll teach patients to do before they go to sleep at night, to do just to help open up all that structure, open up those structures before it self opens up later that night, waking them up.
And then for the over-the-counter posture bracing that patients buy sometimes, do you feel that they help? And if so, what do you have any suggestions on that?
I'm not a big fan of that myself, just because oftentimes individuals will complain about it too much. However, if it is something that will put them in an optimum position and they need to do to perform their jobs, then that is perfectly fine. I don't have one to personally recommend at this time.
I've seen some that will work. There's actually some over-the-counter shirts that don't work well, and there's others that have worked better for some people. But even the ones that work really well, it depends on the patient.
Yep.
So there's no like one type of shirt that works for everybody, or type of bracing that works for everybody. I've seen something as simple as the figure-8 brace for clavicular fractures work for some patients, but horribly for others. And one company does make a postural correction bra that one of my patients loved and another one hated.
Sure.
So it's very patient dependent.
They also have the monitors out now too, where you can clip them onto your shirt. They'll buzz if you start to go into an incorrect posture. So that might be a consideration to help teach them versus just becoming reliant on a support. As we know, if you become reliant on a support, those muscles start to atrophy and make things worse.
So the question or the response to that is kind of like a vibrating dog collar or a invisible fence.
It almost looks like an iPod Nano.
Okay.
Yep. It'll make the shirt vibrate, but hopefully it won't shock you. If that's something that you need to do or have done to you, then by all means.
All right. What other questions do you guys have?
And I do have a list of all my references as well, if anyone's interested in those. You can see a lot of research has gone into this. It's a very interesting topic. Cool.
So please make sure that when you receive the link from my e-learning that you complete not only the quiz, but also the course evaluation. You don't get your certificate until you complete the course evaluation and the quiz. And that should be coming out in the next couple days. If you're watching the recorded version, please make sure that you finish both the quiz and the course evaluation, because again, the course certificate is not released until you complete both. Please contact me with any questions and about the programming, and please contact Dr. Buzin if you have any questions about the specific content. Thank you guys very much for attending.